Astronaut is the first trial ever conducted to date in patients admitted with worsening chronic heart failure who responded extremely well to in-hospital therapy to the point of being relatively asymptomatic at the time of discharge. And at that point, they are randomized to standard therapy or optimal therapy plus placebo or aliskeran. What's really shocking is that in spite of randomizing very stable patients, optimized in all the available therapies, the event rate was astronomically high at 12 months of follow-up. That should be a call for action. That's totally unacceptable that in 2013, among responders, we still have this event rate that has not changed in the last 15 years. So this is about the study population. That's one important finding. That's about patients. We randomize those patients, as I said before, to aliskeran or placebo. Aliskeran is a renin inhibitor. We continue those therapies for 12 months. The primary endpoint showed no differences between the two arms, not only at 6 months, but also 12 months. It was interesting that today we heard the importance of BNP and treating abnormal BNP. Aliskeran was associated with a significant and sustained reduction in BNP throughout the study. So this laboratory measurement, that's an index of progression of heart failure, did not translate it into clinical benefit. My hypothesis is that this was most likely related to the fact that patients that have diabetes had more side effects related to aliskeran. I'm talking about hypotension, high potassium, and worsening renal function. In fact, when you look at the pre-specified subgroup analysis, we see that aliskeran has a bidirectional effect. In one hand, increased mortality or event rate in patients with diabetes, representing 40% of the patient population, but also decreased mortality in patients without diabetes. It is also interesting that the strong interaction was not seen to any other subgroups, 25 subgroups. So this is the only interaction. So I think there are two important things that I will report. One is that this unacceptable event rate. We as a society, we have to do something. We cannot accept this event rate. We have to do something. And two, the results of aliskeran, that although the study is negative, raised the hypothesis that one size doesn't fit all. So we have to stop talking about heart failure and identify those subgroups that are likely to respond. I think for too many years, heart failure was treated as a fever. Well, heart failure, let me tell you, it's like a fever. So when you tell me that someone has heart failure, it's like, say, fever. So what we have to do, if someone tells you that a patient has heart failure, your answer should be find the disease within heart failure, because it means absolutely nothing. Heart failure is a manifestation of different cardiac, that's one expression with aliskeran that may have a different effect. We've seen this in patients with or without CAD and patients with or without renal failure. So overall, was a neutral study, was a negative study, but important messages, important lessons that I learned as a clinical trials from the study.
Thank you very much. Dr. Boesky. I'd like to congratulate Dr. Gheorghiade and the investigators on this well-designed clinical trial. I'm Bicam Boskert from Baylor College of Medicine in Houston, Texas. I have several points. First, I'd like to acknowledge the call for action by Mihai in the sense that even in the placebo arm, not only in the treatment arm, the event rates of 25% heart failure readmission rates and approximately 36 to 37% all-cause readmission or cardiovascular readmission rates are too high. And we haven't made much of a dent in the event rates in heart failure. Having said that, having acknowledged, the hypothesis was a good one, meaning more complete or upstream inhibition of renin in patients who are high risk for this. And we have noted in the past that patients who were treated with ACE inhibitors or other renin-angiotensin aldo antagonists had high renin levels. So the concept, the hypothesis of more upstream renin inhibition made sense. Now, why did the trial fail to demonstrate any efficacy? Perhaps one answer could be we may not be able to demonstrate the incremental benefit, which may be very small, with add-on therapy when we have numerous medications on board targeting the same axis. In this trial, which was conducted well, 85 to 86% of the patients were on ACE inhibitors and or ARBs. Approximately 55% were on mineralocorticoid receptor antagonists. Perhaps those should have been the high-risk patients for high renin levels, but also those are the individuals who are going to have lower event rates because they are optimally treated with conventional heart failure medications. So that dichotomy of optimal treatment, which is going to result in lower endpoints, is an Achilles heel when you're trying to do targeted add-on therapies. Thus, the benefit or efficacy may have been too small for us to demonstrate with add-on therapy. Now, of course, one litmus test for that hypothesis could have been if we were to have seen differences in subgroup analysis according to the PRA levels, meaning those with the high renin activity levels demonstrating better benefit, which we didn't see. That may be a power issue, post-hoc analysis, statistical issue, or in essence, maybe we didn't see that much of differentiation in the risk factors for those individuals with high or low PRA levels, which I'm going to come into. The other interesting thing is what did the renin inhibition do to the PRA levels in the overall population? That may be a subsequent study to look into in the future. The second potential concept, which has been, I think, alluded to by Mihai, is the tipping point of benefit versus risk. In terms of combined endpoints, when we are conglomerating of overall benefit, there may be subtle effects from adverse outcomes, which were significantly worse in the aliskiren arm in terms of hyperkalemia, renal failure, and hypotension. May confound the clinical endpoints, readmission rates. And thus, in the sense that if the increment or the benefit were to be too small to discern, perhaps the side effect profile is robust, especially in a high-risk population, 41% of which were diabetic. At that point, the overall net effect may be neutral, and if you were to dissect it out, you may see the side effects in terms of the adverse outcomes. Still may result in a neutral outcome with bidirectional effect. In terms of perhaps the surrogate endpoint of the beneficial effects on the NT-proBNP, which is sort of our litmus test of what's happening to the filling pressures, it was a good signal that the levels continue to decline with aliskiren therapy. And the other impressive thing was from randomization from screening to the randomization, there was a significant drop in the NT-proBNP levels, telling that the background therapy in each arm was pretty good. So that surrogate endpoint, which may be a good favorable litmus test, needs to be tested, of course, in the future. Currently, that signal is requiring further investigation as to what's the reason, what's the pathophysiology, why did we see a reduction in filling levels, did we cause more of renal failure in those individuals, will need to be dissected with further studies. The risk signal in diabetes is there. We've heard about it before, and it's obvious that this study also validates it. And diabetics are, of course, more prone to kidney problems, the type 4 renal tubular acidosis, hyperkalemia, and thus was seen as a increased mortality along with also increased side effect profile in those patients. Now, whether there is a benefit in the non-diabetics will need to be tested, probably in a prospective manner rather than a post-hoc analysis, which currently remains unanswered. And in terms of where do we go from here with perhaps renin inhibition, I think we'll need to see a little bit more mechanisms and what happens to the PRA levels and who's benefiting and what's happening to the kidney levels to give us an idea what we need to do perhaps for the non-diabetics. But add-on therapy for heart failure has been challenging. As you are all aware that we have had paucity of positive trials in clinical trials, we may have reached a plateau over which we may be having difficulty showing incremental benefit. This is for the overall heart failure population. When we look at the acute decompensated heart failure patients, we have numerous neutral studies. Thus, this is a very challenging population. Though this was a very unique design of acute followed by post-discharge, I still think that we need to keep trying and perhaps do more mechanistically designed studies, perhaps with individualization of therapies according to response to therapy. Thank you.
Thank you, Dr. Bosker, for your comprehensive comments. Our next speaker is Dr. Ali